my colleague, just to talk about what we will be doing today. So we just did a quick review. Farhad is going to step in and talk about microplans and social mapping. And I think in there we might actually talk a little bit that came up in the last couple of days of how do we strengthen this whole community engagement and involvement of communities, etc. So we'll see like how we can actually use our microplans, our social mapping, where this is important. I would like to take a few minutes to talk about IPC, interpersonal communication, and working in the context of COVID-19. We will look at this more in depth when we go into NOPV2, because that's a lot more practical and we need to speak about it and the issues that arise. But this will just be a few quick slides to talk about that. Because we do spend a good part of our time working as facilitators and trainers. Coming back to what I was speaking about, like how are we increasing these soft skills through our supportive supervision, coaching and mentoring, and something the GPEI is actually looking at in one of the huge modules. It's like strengthening that pillar. So we'll talk about that for a few minutes, and then the introduction of NOPV2 and what we'll be doing in the next training. So with that said, I'm going to hand it back over to Aaron, if you and Farhad would like to proceed with the microplan session. And I've kind of put extra time in there. We're flowing a little bit different on our time of the year. But I actually have it down for 45 minutes, but I'm totally fine if we can push that a little over if need be. Otherwise, we'll go into the IPC. There's a big possibility we might finish earlier. We're a smaller group, and as we go through that. But over to you guys. Thank you.
Thank you, Lauren.
Shall I start?
Yes, go ahead, Farhad. And I've once again, for any colleagues joining recently, the link to today's presentations is in the chat box. Go ahead, Farhad.
Okay, thank you. Well, good afternoon, good morning to everyone. My name is Farhad, and I'm CFD consultant with UNICEF Polio team, Global UNICEF Polio team based in Geneva. I'm part of the rapid response team and provide support to the country officers facing outbreaks of CVD-PVs. And I will be talking about microplanning today. And I would like to encourage questions, comments from you. It would be important that you leave no unanswered areas. So because microplanning is very important and is an essential part of the outbreak response. And very often, and I've seen it myself, that poor microplanning sometimes run the risk of poor coverage during the vaccination campaign, because we miss children, we missed entire communities sometimes. Anyway, can we proceed? Yes, I have a question for you. And oops, I lost my presentation. Okay. Flip. Okay, and I would like to ask you the question. When I say microplan, what is the first thing that comes to your mind? It's a question to all participants.
So the chat box is open if you'd like to write, or you can unmute your mic. We're a small group today, so feel free to unmute your mic and speak up in response to Farhad's question. In the chat box, Douglas notes EPI campaign.
So EPI campaign. So microplanning is is related to EPI campaign. Any other ideas what microplan might mean for us or for polio outbreak? Say it again, please. Visualize maps. Good. Visualize maps. Any other ideas?
Tabi, please go ahead.
Thank you, Fad. I think a micro plan is maybe a document where you go into details of all the different parts you will need. Like for instance, this campaign, it will have to look at the different components of the EPI service delivery. What do you need in cold chain? What ice packs will you need? What vaccinations will you need? Vaccines will you need? How many health workers? How many immunization posts? So it's more of detailed micro of what you will need to do whatever you want. If I may just try to explain, if I may relate it now to maybe our C4D or health promotion, you are looking at what are those information tools will you need and in what quantities, which people are you trying to reach, when and how. Let me leave it at that. Thank you.
Well, great, Tablet, spot on. I think it's the right question. I mean, the right answer. You mentioned almost everything. I'm thinking maybe I should close this presentation and then we can go further. Now, it's I agree. I'm also looking at the comments, and some of the comments exactly reflect what macro planning is: mapping of important features or variables for use for an event, working with communities to identify components needed in immunization and related activities, mapping of locations for vaccination sessions, including target population. Great answers, and I thank you for that. Anyway, can we proceed? So basically, as you mentioned correctly, microplan describes the physical locations of target children, as well as the available resources with the specific villages or community that will help us to access those communities, those children. Sometimes microplan is called area plan, and microplan starts around the health, usually with any vaccination campaign, taking, be it measles campaign or polio campaign, it starts around the health facility, because that's where the information is. This is where the vaccinators are. This is where the vaccine will come. And each health facility, better than I do, has a catchment area. So that catchment area will be used for polio as well, for polio vaccination campaign, and the microplan will include anything related to vaccination, including, as you rightly mentioned, can we proceed? Next slide, please. Will include, exactly the information, how many vaccines we need, how many vaccinators we will need, vaccination teams, schools, villages, etc., and target children. So the objective, why do we need the micro planning? So first of all, we need to identify and adopt strategies. How are we going to reach all eligible children? We also need to know how we're going to mobilize communities and other stakeholders to support our campaign. We need to know how much money we will need, or how much resources we will need, such as if we talk about social mobilization and communication, we need to know how many social mobilizers we will need, how many days will they work, how many materials will we need, trainings to be done, where we're going to display our materials, etc., etc. A lot of details, as you rightly mentioned. It's a very detailed plan, and it's an area plan. And then all the small area plans will be consolidated in a district plan. And then the district plan will make, I don't know, a bigger administrative unit plan. And of course, we need to all this information in order to supervise and document our activities. Next slide, please. So this slide, on this slide, you can see a very colorful map of sort of macro planning. Yeah, and it's and we all like this, small pictures, small graphs, and something that attracts our eyes. But that actually is not really, it's it's only part of the micro planning. So, and here you can see, different roads. You can see the area that you might cover on the day 1, on the day 2, on the day 3. You can see that where the cold chain facility or house facility is. We can see the church or mosque, religious structures, schools, etc., etc. So it depends on the local area. But that's not the micro plan that you will see and that you will, together with the EPI colleagues, will be completing. Next slide, please. That's the nitty-gritty of and I think it's less exciting to see this kind of. You will work with the spreadsheets. And it's just the kind of pace from the micro plan itself. You can see that there's a lot of demographic data. So there you have villages, population size, number of households, number of children, because that information is critical. Without this information, I don't think we will be able to do anything. Then we identify high-risk population. We put the challenges, how we will get to that high-risk population. We come up with the messages for them. We will need to think of who can influence those communities, and then we will put the activities, and we will put the responsible community health worker for those activities. The places. Each plan will see the schools, the religious institutions, as I said previously, health facilities, market, malls, against shopping centers. We will need to know the transit points, bus stations, or I don't know, somewhere where there are crossing across the river, water points. And for the general population, we will need to identify where, if and when are we going to have advocacy meetings? Are we going to have community conversations are we going to advertise through community radios? And again, we need to identify who will be responsible for that. Anyway, you will see that in your micro planning when you will do it. So this is sort of dry, less attractive, but still important part of the micro planning. It's not going to be only, let's say, communication, health promotion colleagues will be responsible for that. They will work with EPI, with vaccinators, because each team, as you may know, will comprise of vaccinator, recorder, and social mobilizer, or health promoter, or community health worker, etc. Next slide, please. So, as I mentioned, these are the main components of the micro plan, and we heard of this. We heard this already. The micro plan will tell us how many vials we need, or how much vaccine we will need, what kind of logistics will be involved, how many cool boxes we will need, also human resources. Of course, it will, again, I'm repeating myself, but it's important. It will list all the towns, villages, and settlements with the population. Individual team microplans. That's where, again, it's important with the clear description of the day-wise area, the one that I showed you, and I will show you exactly again how teams now being very innovative and using Google Maps to do their day-wise area mapping. Again, high-risk areas, list of special sites, transit teams, border area plans, etc. The most important thing, micro-planning should be done with the involvement of the local communities, and use all possible resources of sources of information. And we will talk about the sources of information later. But look at this red So each micro plan should have a social mobilization and communication plan. That's where this is the crux of our, let's say, communication, advocacy communication, and social mobilization, as sometimes we call it. Next slide, please. So what is the communication plan or micro planning for social mobilization activities? Key components that you need to bear in mind. So who is the social mobilizer? You need to know the name, the deployment, what is the area of responsibility for that person, exactly, because the activities, as you may be aware, or may know, the activities will start before the campaign. Sometimes they start 2 days, sometimes 4 days. It all depends on the context. And sometimes the activities, social mobilization and communication activities, continue throughout the campaign. But it would be important to start earlier, the social mobilization activities, because communities, caregivers needs to be informed. So the day-wise activities needs to be done. For example, interpersonal communication should start 2 days before the campaign. So you will need to train the social mobilizers with the key messages, give them information about the campaign, especially the dates, the eligible children, and the age of the children, and other details of the campaign. The IC materials, again, they shouldn't be arriving when the campaign has already started. They should be up in the places displayed before the campaign. The micro plan will tell us, how many banners, posters, and other visibility materials and distribution plan we will have. Again, if you engage megaphones, and especially there's big loudspeakers mounted on the trucks, on the vehicle, then you need to have a route plan for them, because that depends also, the transportation cost will depend on how many this vehicle you will engage, where will they go, how much petrol or diesel they will consume per day, and etc., etc. And town criers, where exactly they will go. Now we're being very strategic, because the funding, as you may know, will not be, as it used to be in the past. So we will need to be very, very strategic. And of course, the advocacy and community awareness, meeting with influencers. Next slide. Social mapping, sometimes it's, we do it, but sometimes I've seen that the teams don't do it because they kind of know, but it's important part, is an essential part of micro planning. And I would highly recommend that each country facing the outbreak do the social mapping. Whatever you do now will serve you a good deal in your routine immunization. Whatever information you collect now in preparation for the polio vaccination will serve you a good deal in your routine immunization again, because social mapping will tell you the topography, the important geographic consideration. Sometimes and especially it's relevant for Africa, we have floods, rainy seasons, sometimes the roads washed away or inundated, etc. Sometimes bridges are washed away. So we need to know and update this information so that for some reason the vaccination or at least the social mobilization is not stuck, and population are well aware of the campaign. High risk groups. you identify those high-risk groups. Probably it will be nomads. They might be city dwellers, those who are inaccessible. There could be migrants who are hiding from authorities sometimes and not seeking immunization, and they might be even running away from immunization for various reasons. So those high groups needs to be identified, or remote areas even. It would be good to look and speak with the local communities and especially health facility employees about the location and cluster of refusals or absences. Sometimes we know them, sometimes we don't know, and but the local people will probably know, and the local health facility will have this information, might have this information. So who might influence the communities? This information is important. Location of community infrastructure, mosque, churches, school, the healers, clinics, markets, again, pharmacies. These are important community infrastructure to know about. Ethnic and linguistic makeup of population. So if some communities may have different groups that speak different languages, or the areas districts, so we need to know about this when you send the vaccinators or social mobilizers, that person needs to speak the local language. Local media, radios, of course, you know this, and social, again, location and names of social mobilizers. Community organization, we talk about the faith-based organization. These are probably key, and in many countries, we heavily rely on faith-based organizations, on mosques, on churches, and they do sometimes campaigns organized around exactly the time when a lot of people get together in those institutions, or let's say they visit mosques, or they visit churches, and this is where it is the impact, you know, the communication impact can be can achieve its, you know, the highest objectives. Security and accessibility challenges also will go into social mapping. Can I ask you a question? Is it all clear? Am I not speaking fast? I guess it's okay. Next slide, please. Okay, this is a kind of a day-wise movement. And here you can see on the left, this is something hand-written, or let's say hand-drawn. And it's again the map. If you can, unfortunately, I cannot see, we cannot see the full map, but you know, these areas, the green and the red, they represent certain days, for example, ending point, and this is like a middle point, somewhere it starts. So you basically put on the paper, on the I don't know, on the flip chart paper, the whole community. Nowadays, what they do, all of us will have, well, many of us have the smartphones and then have access to Google Mapping. And I took it from the Northwest Syria. That's what they did. And this is the vaccination team. And they just basically took the screenshot of this and put the arrows. And then they said, okay, this is how we move. And you can use this. It's quite innovative. If you want to have a, let's say you put the market is there, the church is there, and then when do you need to go to that marketplace and then do the megaphone announcement, etc., etc. Or the, so that's possible too. Next slide. So, developing the plant. What are the essential elements of the development? Next slide. We can go further. Data collection. that's the key. I think if we don't get the updated information from the communities on, you know, on coverage or IM data, if you have it, even from the previous years, then it would be hard for us to plan, because the micro planning will have this information. For example, if we know, when we look at the secondary data, immunization coverage or IM data, we can see already where we last time we had missed children or absenteeism, and then we can focus on those areas. Yeah. Again, there's no need to get into low-hanging fruits. As we say, the good guys will take care of themselves. We need to go and help the weak part, or those who might not, fall behind the in immunization, or defaulters. Explore the reasons for missed children and absence. That might come from the focus group discussion or CUP studies. A very good source of information if you have a social investigation. So in the social investigation, which is done for sometimes for the family, affected family, for a child, and also for the community. There, you might see the reasons why children missed immunization or missed out the vaccination during the campaign. And that's the I put this as an example, the reason of missed children in Sierra Leone. This is a consolidated data for 2016 and 17, and it's based on the available data again. This might not be inaccurate, but that's what we had data. And then you can see that refusals is not a big issue in here, but absenteeism is unacceptably high again, because look, in March, almost 5% of the missed children were absent. In February, same story. So we need to understand what is really happening. If in March and February, whether it was a farming season, or why so children, or look, if we see that February, April, September 16, October 16, and then, the multiple campaigns sometimes, affect the willingness, or may create the hesitancy, because people are getting tired, they have caregivers feeling fatigue of the multiple campaigns. And that's why it's important to understand and work and come up with specific messages. Next slide, please. Once you collected the data and reviewed the data, analyzed it, so again, we're talking about not the whole micro planning, but the social mobilization plan, micro plan. Clearly state the goal, objectives based on the findings, and identify the key persons or key stakeholders who will be engaged in microplan development. And that could be implementing partners, Red Cross, well, I don't know all these abbreviations, but it could be religious leaders, traditional leaders, community leaders. It could be the chiefs, sheikhs, imams, priests, you name it. It just depends on the context and on community, and of course champions. So that basically we need to think of who might help us in implementation of the social mobilization activities. Next slide. Just one point. When we get one community health volunteer, you can imagine, in a day, a person can probably make, if the person is on foot, can make, I don't know, visit 20 to 25 households, or maybe 50 at once. So And then if we have only 4 days before the campaign and 2 days in the campaign, that will probably not be enough for one person and will require the support of the community. So developing an action plan. So the solution should be discussed to challenges. So for example, if the radio somewhere is not covering the area, so what to do this? The best approach is, of course, to use the to use participatory approach and to hear all members of the community involved in developing the plan, identify either with the problem tree or the matrix all the challenges and put the solution in. Map out community resources that we can leverage again. These could be, community groups, schools, churches, etc. And identify channels of communication. Again, it could be community meetings by community health workers. It could be the loudspeakers. It could be IC materials or radios or television, etc. And of course, adapt the messages based on on your data. Next slide. And this is a template for developing the action plan. Here you can see the objectives that you put. You can say, raise the awareness of the campaign of this villages, and then what kind of activities you will put there, what kind of logistics you will need, who will be responsible, and of course indicators, and put the timelines for that. And that needs to be disseminated. This plan and the roles and responsibilities should be disseminated to all stakeholders and partners. Next slide, please. I think this is the last one. This is the last slide, and I thank you for your attention, and I would be happy to answer your questions and hear your comments and experiences. Over to you, Erin and Lorraine.
Okay, so the floor is open. If you have any questions for Farhad on microplanning, social mapping, any comments that you'd like to write into the chat box, we have time for that now.
Erin, I just wanted to make a comment and to really thank Farhad for doing this, because as we all know, and from our work, it is extremely hard to do a session on microplanning and social mapping when you are not on the ground. I mean, this is a very practical exercise and a process where we go through and we look at the data that's available in country, and work together in teams to do this. So please bear with us while we try and do this with Zoom, and thank you, Farhad, for taking this on.
Thank you.
Thanks, Lorena. Douglas, I see a hand. Go ahead.
Yep. Thank you very much for the presentation. I must say that that whole process really requires a lot of capacity building at the lower levels. And as UNICEF, we greatly depend on the capacities on the ground, especially in the Department of Immunization with district health officers. And this is a question which I'm just going to put across, because I know that getting that capacity in place and making sure that it's efficient requires a lot of money. And sometimes you have to either get a partner to do this, but under the current process, as you look at Uganda, for instance, how much support are you envisaging to provide to Uganda to make sure that there is that capacity and to oversee it for a reasonable period of time? Thank you.
Shall we collect a couple of questions or comments and then we answer, or shall we answer this question and then answer each question as they come in?
We can answer each question as they come in, yes. So as colleagues can continue to either raise your hand or enter into the chat, but for now we can respond to Douglas's question. Go ahead, Farhad.
Yeah, Thank you, Douglas, for this great question. It's a very difficult question to answer. And especially knowing that the capacity in many, in many countries where we work, where the outbreaks happen, it is not up to the level, or it's not as we desire. And yes, and it's costly. But from my modest experience, what I've seen, it's the knowledge is there, and the communities themselves, they know. If you go, we're not doing the polio vaccination in Uganda, let's say, or Sierra Leone. How many times we've done COVID? Yeah, so it would be best. It would be probably use or leverage local resources as much as possible, and identify the specific needs of the community, and they will tell you what is probably they were lacking, or they would like to sort of upgrade their skills and something. And then you might put this into the request in the budget, so that the micro planning is not an easy. We need to teach communities to do the micro planning, and that, of course, costly. And agree with you. But again, knowing that we might not have enough money for that, how can we best do this? Are we going to work, we train someone, and that someone will be helping communities? Can we use innovative approaches? Can we use WhatsApp? Can we use other platforms that, instead of going there, we can work with the communities? Can we train someone, and that someone can go and teach local communities? And again, much of the information is already there, and communities themselves. For example, if you ask someone, I don't know exactly, maybe I haven't worked much in Uganda. I know Uganda and I've been there, I've seen it, but I haven't worked on polio there. But from other countries, I've seen that in the health facilities, there's information. And if you talk to sheikhs, or if you talk to community leaders, if you talk to religious leaders or other, they probably give you a lot of information that will help you to develop the plan and the social mapping. We also have our partners, Red Crescent Society or Red Cross Society, the national representations. They have their volunteers, and they're using, I know that in many, for example, in the Philippines, we rely heavily on them. In Sudan, we again ask for their support, because they come with the grassroots knowledge, with the exactly community knowledge, and they represent communities there. I don't know if I answered your question, but I'm just giving you some solutions that might be worth considering. Over.
Yeah, you've done so totally. Yeah, thank you very much.
Wonderful. Thank you, Douglas. Thank you, Farhad. What other questions or comments do other colleagues have on this topic? I see some action in the chat box. Abel has commented that with the use of microplans, it's helped him in supervising the activity, because then you know the location of the activity, who is involved, and for how long. And he comments that the challenge is when the team implementing changes the dates and doesn't inform you. And then we have a question from Qatar. You spoke of starting IEC 4 days before the campaign and IPC 2 days before the campaign. Is this conventional, or it might be used in, or it might be country specific, community specific, depending on the scope or the reach of community, number of communities to be reached?
Yeah, thank you for the question, Qatar. I know it's just an example. Look, sometimes we may display our IC materials a week before, sometimes 10 days before, depends on the local context. Again, I just want to make one point here. IC materials, I think we are slowly moving away from printing massive quantities of the IC materials, posters, etc. We're trying to shift a lot into the digital world. We know that people are using the mobile technologies. They go into Facebooks, they go into WhatsApp, they are following the media, the radios. You again, please, data will tell you something. Just don't go blindly. Look at the data, what it tells you. But again, the number of days will depend on the local context. You can put the date, the IC, 10 days, 15 days in advance of the campaign. Same for the IPC. But again, IPC is difficult to organize because it's part of the training. It especially in COVID times, you need to think how you will organize the training, and then will you have time to do the whole training for social mobilizers, or will it be part of the bigger team? That will be the decision by the GPI groups when they will discuss the nitty-gritty details of the campaign. Again, very important to be part of that discussion, because sometimes countries going save money, and then they do a one-day training for the whole team: social mobilizers, vaccinators, recorders, etc., etc. Yeah. That is it. Microplans, when complete, are very resource. However, the generation of required data is not easy because some of our districts have several places to map. For example, 100 schools. To avoid bulky plans, can consider actual school name as say places. Yes, a very valid point. Some plants might be very bulky, depends, especially in the urban areas. But again, if you break down into smaller pieces, I agree if microplanning starts with the house facility, and that's the usual way, because again, where the vaccine come from, yeah, and then what is the catchment area, and then from there will be teams. Each house facility, for example, a house facility may have several teams, and each team will have its own catchment area. And then in that catchment area, there will be, some social infrastructure there. And mapping that would be, yes, try to do, not to do it bulky, because then it will be very difficult to follow. During the micro planning, is it good to discuss supervision and monitoring? It's not only good, it's great. It's better to identify it immediately so that activities will be supervised and monitored. It's great if we plan, but if we don't monitor, we don't know whether the activity is actually taking place. We have to rely on the data that we receive, but then sometimes we can go and randomly select the areas. And especially, again, I would recommend maybe to visit fewer places, but visit the most difficult places. Yeah. Sometimes we can receive, nowadays, I've seen that myself. The managers, what they did, supervisor, what they did, they organized the WhatsApp group and they received the daily reporting. If it was a training, if it was an advocacy meeting, pictures. If the mosque or church is doing something, pictures. If just pictures, sending pictures through WhatsApp, and it's also it's a way of monitoring activities. And supervision, of course, again, we can, because of this, we have now access to WhatsApp, Messenger, etc. We can even provide our supervision advice and I don't know, coaching to these to the health to social mobilizers. I don't know if I answered the question, but if you have further questions, please go ahead and ask.
Yeah. Hi. This is Lorraine. I just want to add on what you were saying, Farhad, about the whole part of IEC and IPC. And just to add to that, yes, it's also going to depend on the circumstances, because you could do IPC a couple of days before, but remember, you could have some hesitant families or this, et cetera, which you have planned out, right? So this could be something that you have to go back to and address. And that's why the supervision is also good, to make sure that you're reinforcing what you're doing.
Yeah. Micro planning and then implementation of the activities of social mobilization activities is tough, but if you plan it and put the dates and responsible people and get the feedback from responsible people, I think it becomes easier. And then remember, that's where will be done the first time. It might be a little bit clumsy. It might be, you may run into challenges, but the second time it will be easier. And again, I'm sure that we've done many campaigns previously, measles, yellow fever, even COVID. You just name it, you have this capacity, you have the knowledge. Just, we need to smartly use it now, strategically, because we might not, it's polio campaign, it's not COVID campaign, probably you might not have enough money or what we are planning. So that's why we need to be a little bit more strategic.
Thank you so much.
It's probably a lot more strategic.
Thank you, Farhad, for this incredibly important session, and thank you, colleagues, for your questions and your comments. I'm not seeing any more hands or comments in the chat box, so I think at this point we can close this session and turn to Lorraine. I invite you for our next session on IPC and working in COVID. And to note for any colleagues following along in the materials, in the link that we shared, this is session 10. There's one presentation for IPC. I think you're on mute, Lorraine.
Okay. Yeah, I'm just pulling up the presentation. Yeah.
Excellent.
Bear with me for a second.
And I can share the link once again if anyone has lost connection and rejoined.
Aaron, in the meantime, do we have any other questions that came up?
So far, no. If anyone else has comments or questions, feel free to unmute or to add your question to the chat box. We'd love to make sure everything is clear from the last session before moving on to this topic.
Thank you, Aaron. Thank you. As I mentioned earlier before, that we're really trying. I mean, it's as you all know from the work that we do, it is very hard sometimes to do these presentations that are supposed to be, these sessions that are supposed to be extremely interactive and very practical and working on the ground, where we can work them into simulations and actually have discussions based on them. But anyway, I'd like to take a few minutes to speak about interpersonal communication. It's important. It's a big part of what UNICEF does, not just for the polio program, but of course for a lot of our social mobilization and across the board, and one of the pillars that we carry. So if we just take a few minutes, look at it as a reflective moment and just review it really quickly. I put this slide up over here because I think it is very important. I mean, when we started talking a couple of days ago, and I was talking about the health worker, and based on what Farha just said and all this data, that everything comes down to this. And even as our colleagues were speaking earlier, right? We can have the demand, we can have the supply, we can give you the access, we can give you everything that we have done. We can train you, we can use the radio, but it's going to come down to this moment. And one of the most important things for us is to make sure that that health worker has the right communication skills, whether it be going door to door, or whether it even be in a post or in a clinic, in a community clinic or something. IPC is extremely critical. And I think a good way to always remind ourselves about this is just to look at ourselves and what would keep us going back to see the same doctor or to change our healthcare providers. So when we think about communication, we think about communication in multiple ways. I am going to open this up if anybody would like to add to this conversation or this dialogue. I think sometimes when we think that communication just means how we speak, but it's not. I mean, there are multiple ways that we can look at it. And just to see if there's anybody who'd like to give me an example of when we talk about like nonverbal communication or one of these other groups over here.
What's that body language? Road signs.
Yes, Metzger and Muhammad, do you want to add something or an example? Go ahead.
You are asking about for non-verbal communication. An example, I want to believe road signs. They are non-verbal, but you can be educated through the road signs or body language. The use
Absolutely.
of body language. Yeah. For non-verbal type of communication.
Yeah, very, very good point. You know, you're absolutely right. And when I'm actually looking at this right now, I'm just thinking about what just happened in the United States for the last couple of days, where you're actually just looking at images itself. And that is a very strong form of communication that comes across that would be something good to add on there, you know, when we look at this. And also a good reminder of who our target populations are and when we speak to them. And when I was speaking a couple of days ago and I said, you know, sometimes we might use posters that kind of show negative images versus positive. As health promotion officers, we're always trying to look at positive things, but sometimes we actually use shock and awe. If you look at a cigarette packet, you see these lungs of someone laying in a morgue, you know, that's a very visual way of looking something and how we communicate skills. Anybody else like to add anything? Okay. But just a clear reminder, I'm just going back to that photo. You know, when you look at this photo and you can even see how they have, this is from South Sudan, the handout, you know, the shaking of the hands and stuff. I mean, imagine if you just showed up at someone's door and you look extremely lethargic and like tired. I mean, we know this, and it's more just how do we pass these information on, especially when we look at our frontline workers who are already so fatigued and so tired and walking out in very hot environments, maybe walking all day. So just a reminder that the interpersonal communication, of course, is the face-to-face communication. We don't in particular like one-way communication. That's why it makes some of these trainings a little harder for us. And we prefer to always go into this form where we can create dialogue, use our listening skills, and work together and listen to what people are saying. Why do we like to use IPC? Well, it's credible. It gives detailed information. And if you think about the detailed information and you even look at today, what's going on in the world, we might be able to go to someone's household if we spend the time to go there to use the opportunity to also give more information that's important. It allows feedback, of course, sharing of ideas, and it reinforces. Reinforcement for us is a critical thing because when we look at some of these other levels of where we work with people and how we communicate with them, people don't all learn the same way, right? And sometimes hearing something that's repeated over and over helps to reinforce the message. But then we come back to this part that reminds us that it's also very time consuming, it's costly, and requires skills. So I think Farhad, there was one of us colleagues had thrown the question out there. When are you using the IPC and when are you using your IEC, right? Which have completely two different reasons why we're also using them. One of them is raising awareness. Yes, it reminds people, but the other one's actually getting down to this nitty gritty, soft hesitancy, may vaccinate, may not. I want to bring in my IPC people and help to change that, but I have to remember it can be quite costly. Or how do you even strategize when Kashan went through the little animation, right? Like how do you quickly move these teams to get around? So just a reminder, when we talked about that image in the beginning in South Sudan, when we think of our health workers, we think about all these things, and we think about all these things that we've even discussed over the last few days. Trust is critical, risks that you can discuss more, what happens when you have multiple rounds, right? Things that you might even just be hearing that simple message that's coming across the radio in between breaks, public service announcement, but here we're given this opportunity to actually address these things more in depth. A few reminders of when we do our IPC work, to make sure that the information is shared and is understood, especially by the frontline worker, is that a critical source of information. Things that might come up, why are you using drops versus injection? Are we making sure they have the right information, especially when we look at going out with a new vaccine now? Multiple doses or campaigns. I have this over here because, as Farhad mentioned, when he was working in the Philippines, one of the things that we'd noticed in the Philippines when we went in and we did a training was that they already had a set amount of campaigns they were going to have. And what happened was they were not able to close the outbreak, and so they had to increase the amount of campaigns. So we need to be careful what the information is that we're giving to people out there in the community. Don't dwell on the technical details of the campaign unless asked. Some of these questions that come up, how do you address things that are about MOPV versus B, versus now when we look at the NOPV, don't give the information on the maximum number of doses. I just spoke about that, right? Because it might come back later to bite you. Understand also when we are looking at our IPC, when we go back and look at the data, understand why children are being missed. You know, if you see these things, like if you look at this middle one over here, which is 22, it shows that children are sleeping, but really, were the children sleeping? And are you addressing what happens when children are sleeping? Sometimes the parent might use that because they're actually tired of people coming door to door, and it is an excuse, and they will just say the kids are sleeping. And so are you taking into consideration then what is your approach to come back with the IPC? I think I'd like to give an example over here of something that happened in Kenya when we were looking at one of the last outbreaks that had happened, and it was to do with the refugee population that had moved from the border with Somalia, Kenya, and Somali refugees had actually moved into Nairobi. With those of you who are familiar with Nairobi, they were in the easterly part of Nairobi, and when people went door to door to vaccinate, there were a few things that we had to take back to the drawing board and to look at this and to adjust our plans. One, when they showed up at the door, they were wearing the yellow aprons that said Ministry of Health. These are refugees. Refugees were not very quick to look at government and to speak to government. It didn't mean that they didn't want to vaccinate their kids, but they didn't want to be in the city rather than being in a refugee camp. So that was one issue. And so the women were very quick to say that the children were not at home because they didn't want to expose the kids. And what we learned was parents wanted to vaccinate, But because we had shown up with people who said Ministry of Health, they were not willing to open the door and had other excuses. So this is where you have to change your approach then, and instead of maybe using people who are going door to door to do the vaccinations, then how do we bring the elders into the community? So a little sample of why it's important to remember how we use our data. Just a reminder, when you do your FLW trainings, to remember those key questions that we ask. These are critical for us. Is there a child in the house? I just gave you an example. Is the child sleeping or sick, etc., etc.? They are in your packages and towards the back of your package. Is the child, these are the same ones. Is the child out of the house at the moment? And so we can also get data as to where they are. Are there any paralyzed children in the household or children under the age of 15? This is also something that plays into our surveillance part. So one of the things that we will discuss next week when we look at IPC, we've always looked at IPC in the polio program, but now we are also looking at shifts that are occurring. And one of the things that we will discuss when we talk about NOPV2 is how do we look at IPC also in the context of COVID-19, and how do we look at this also to address stigmatization, which is important for us to remember this, because these are populations that are going door to door and may not be accepted in some communities. So how do we overcome this? And that will be part of your NOPV2 training. And just an example of some of the things that will be discussed. And also preparing our interpersonal, our IPC for the FLWs, because when they do go door to door and they are working with polio campaigns, there might be other questions that come up. And parents might not be interacting with health workers or social mobilizers. So are we preparing them that they are able to answer some of these other basic questions that come up? This is just a slide that we usually put at the end just to remind people that when we do these trainings, we're trying to make them as practical as possible, right? They're very systematic. We look at the skills of a trainer, we look at data, we look at our audiences, we look at our micro planning, and it's important for us to remember that IPC is also a critical part of the work we do. And with that said, again, this is very difficult to do this just speaking out like this, because IPC is something that's usually done in country. It's very practical. It's part of our exercises. We'll try and do that a lot more in the NOPV training. But with that said, I'm just going to open it up to see if we have any questions. Any examples of anything anybody would like to share with us?
Yes, Lauren.
Yes.
This is Martin. Thank you very much for that presentation. I think it's really very relevant and very appropriate. My comment is around the issue of really how we do the social mobilization and then the IPC, and really we are really trying to create demand. And after doing all this, the population is informed and the masses, they are ready, let's say, they have accepted. And the challenge sometimes is the issue of this demand which has been created vis-a-vis the availability of the service, or the quantities of the vaccines or the other supplies needed. We just had a small scenario where I work in Uganda, in northeastern, where we had a serious outbreak of cholera, and of course our colleagues from WHO, they really had to give the oral cholera vaccine. So we went through together working with them and through the process of social mobilization, IPC and all that, preparing the communities for the oral cholera vaccine. And knowing that actually they are supposed to get 2 doses 2 weeks in between. We had the first round. Of course, we had a lot of resistance here and there. I think we scored something like 76 in the first round. Now, at the second round, when you're supposed to do the second round, actually the supplies were not there. And this really brought in a lot of challenges. And people are saying, if they told us that after 2 weeks, you have to get a second dose, now that we have not gotten, So what happens? Does it mean, again, we have to begin afresh? And so that again made the work that it was done initially a little bit challenging. And people started thinking that maybe the information was not even right, because if it is, then it means we have to be fresh. So I'm just saying that as we do this, the social mobilization and all these preparations, I think also we have to look on the other side, or the supply, as we started talking about it even yesterday and the other day. Really, the supply side is also well prepared, so that to meet all the demand that's going to come in at that time. Or else we are going to face more challenges midway the implementation, and or other campaigns that may come late. That's my comment.
Yes, absolutely, Martin. I'm with you over there. And you know, as you were talking about what we've spoken about for the last couple of days, right? Our job and our role, we know over here what it is and what we are supposed to do to strengthen this, right? And yeah, it's a comment, and it's a very relevant comment. It's like, how do we bring that side of it? I mean, even these questions that just came in about routine immunization, how do we keep that side strengthened so that people continue to vaccinate? And as Tommy was even saying, if you look at when we have some of these outbreaks, you know, it's like, how do we keep that side, you know, which is more complex than just us guys talking as social scientists, you know, looking at the whole other component that goes into government, that goes into partnership to make sure what you were saying is taken care of, you know. And even if, you know, you're speaking about cholera, you're speaking about polio, step out of it and look at the reality of the world today. And I don't mean to dwell on the context of COVID-19. But it's like, even if you just look at some places over here and the community I happen to be living in over here where vaccines have been coming in, and then it's like, what are you going to do for your second round? And for us, maybe a lot of lessons learned, like how do we even keep people coming back to take that second dose, right? It's not a one-dose vaccine, but do you even have, I mean, my first fears as a social scientist was like, can we even get them to come back and take the second fear? But now it's even like, will we even have the supplies in place? And that's on a global level. So yes, working up in northwestern or northeastern parts of this country, it's like, how do we keep the balance of this real reality? I'm with you there. So opening up for discussion for anybody else who would like to add to that.
Yeah, I just wanted to make a submission in regard to what you've just shared. When you look at interpersonal communication and community engagement, I think it's a very critical component. And as we realize with COVID and with polio, it requires a lot of money. But I think for us not to be frustrated, it has to be conducted alongside with the other plans, the advocacy plan and the risk assessment plan, which we had yesterday, because in that process, then you can try to kind of oversee the potential risks. And because if there is a gap somewhere, then we're bound to have a relapse or something. So one of the lessons we've learned from the COVID and Ebola experience is that whole essence of having a good risk communication plan, which includes all the different components, the advocacy, the risk assessment, the community engagement. And once that is implemented in a concerted manner, you try, I think you kind of, you avoid the surprises, and also you kind of can also defend your moves as you move along with other groups, because as communicators, we are working with logistics groups, we're working with finance, we're working with, and when you are in these meetings, if you're not really strong as a risk communicator to really also push it back to them, I think you can also easily get defeated, because always the tendency is always communicators, you're not doing enough, but we are doing our bit, but they also have to do their bit. And then we have to defend all our efforts and their gaps and the weaknesses with information. So that's where evidence becomes critical. Thank you.
Absolutely. And stay positive about it. and pull the plans together. Yes. Anybody else like to add some comments? Tommy? Okay.
Yeah, good morning, everyone. Yeah, good comments. And just a reminder for the NOBV introduction, the plans that are required, the country has to develop the advocacy plan, as Douglas was mentioning, the advocacy plan, the crisis communication plan, and then the C40 plan, which basically, when we speak about risk communication, and this is a term that WHO uses a lot, it's basically what we do in our C40 communications. We inform the population there's an outbreak and there's a risk that your child can get infected, so vaccinate your child. So those three elements: C40 plan, advocacy plan, and crisis communication plan. Thank you.
Thank you, Tommy. I also see a comment from Emmanuel, I believe in targeted IPC and the inoculation theory that serves a great deal. Well, I'm sure you've all seen it. And the target IPC in a very carefully selected audience is something I consent to. Sure, Emmanuel, would you like to elaborate on that for? Okay, I think Emmanuel is back on mute. But in total agreement, I do want to point out here again that let's just remember that IPC is not, it takes skills, right? And it can be costly and it does take time. And as we were saying, and as Douglas has said, and Tommy, we use a multiple prong approach for the work that we're doing. But very important that we speak about, and very important that we continue to do this. And also, I think as we go forward globally, where people are starting to see the value of how this can actually, it's a key component for the change, for behavioral change.
Lauren, just a comment on,
Yes.
on the vaccinators' IPC skills. I think the key group that, unfortunately, we are not very good at training our vaccinators in IPC skills. And when you had that slide about different non-verbal communication, etc., then that's where we look at if the vaccinator is let's say smiling and greeting the parent, how do they dress up for the campaign. Are they greeting the parents? Do they have the knowledge to answer simple questions from the parents? And I know they don't spend normally a lot of time at a household, but if there are soft refusals, if they have the right skills and the knowledge, they can try to solve the situation and any hesitance right away. So, but often the vaccinator training is organized by WHO, and UNICEF is given just an hour and a half on communications topics. So it's not sufficient, and this is something that I've seen in many countries, and it seems to be very difficult to change that because it's costly also when you look at the number of vaccinators and the trainings that are organized. If you add a half a day, then the budget just goes up a lot. So unfortunately, that's the reality. But I think it's along the social mobilizers, the vaccinators' IPC skills are critical, and I think the program could invest more in that and would immediately get better results, in particularly areas where there are vaccine hesitance and where there is a need for some more dialogue at the doorstep with the parents. Over.
Yeah, thank you, Tommy. And actually, a big point Tommy just reminded me that we should be stressing when we do our trainings and we look at our stuff. When we come back from our break, we're going to talk briefly about soft skills and looking at this as facilitators and trainings. And, for as long as, well, for the few years that I've been working in the polio program, and you look at the trainings, there's been such a heavy focus on looking at the vials and making sure they can give the 2 drops, and how do you dispose of this, and how do you blah, blah, blah. And one of the things that we've really been advocating for is focus a lot on IPC, this emotional intelligence, what happens when this person comes to the door. And now we're starting to see a change where you're starting to see a lot more of this little, not a lot, but a shift of saying, what are we looking at with some of those other softer skills that we need to strengthen? So like Douglas, as you brought up, when we look at these plans also and these strategies and we put them in place, I think we should really also try and advocate that we are giving a little more time to focus on this and to train. And maybe with the global shift of seeing how complicated it is to look at human behavior, that we might be able to get a little bit ahead of ourselves over here. Yeah. Okay. All right, if nothing else, Aaron, I'm going to hand it back over to you so that we can take a little bit of a break. I really appreciate you all tuning in at this late in the day to be with us. But we have like, just to review supportive supervision, which won't take us that long, but we can discuss it. And then introduction to NOPV2 training, and then we can call it a day. Well, for you guys, not for us over here. But maybe we take a quick break. About 10,
Yes.
15.
How long do we have for it? 15?
Shall we just come back on top of the hour? So
Perfect.
Yeah.
Yes. Okay. So thank you so much, everyone, for your participation this afternoon. Take about a 12-minute break. I'll put a timer up on the screen, move around, and we look forward to reconvening for our last 2 sessions of the training.
Yeah, which will be quick. So do come back. Hey, Erin, it's me. If you're there, I have a quick question for you.
Yes.
I just shared a link with you that I would like to eventually have it go out. It's the link to everything in the Dropbox here.
Yes. Mm-hmm.
If I wanted to share, actually, I'm going to have you do it if it's okay from your end.
Yes. Mm-hmm.
Before I go in the next session, I just want to show people the tools that are there. So what I'll end up doing is we'll end up looking into multiple folders.
Okay. Do you want me to project this? I'll share it in the chat box and project this browser page for you
If
to
you
talk.
could, please.
Sure.
And then I'll just have you click. So if you just check it to make sure it works.
Yep, it works. Mm-hmm. And resources to share.
Then my computer seems to be very slow this morning. I think I need to reboot the whole thing when this training, as soon as the training's over, before I start working. Okay, but
Okay.
you have it, right?
Yep. Mhm.
All right, I'll be back in a couple of minutes here.
Great.
Thank you.
Okay, everyone, welcome back to our last 2 sessions of the training. So I'm sharing in the chat box a link. This is a new link that contains all of the training materials. Before we go into the next 2 sessions, we will look through some of the resources that are being provided to you as part of this training. So I'll add this into the chat box now, and Lorraine can walk you through some of the materials to give you some orientation of all of the tools and resources that are included.
Yeah, thank you, Aaron. I just wanted to share this with colleagues because, Aaron, if you can pull it up on the screen, please. Because I know we have been sharing some of the presentations that of the sessions that we were going through, but just to show you what we do when we conduct one of these training sessions. If you can see, this is broken down into modules. If you click on the modules, and in there it will have all the training modules of the sessions that we've had together. Some of them you will notice they will actually have folders in them, like if you click on polio basics, for example. Okay, so what I have done, besides just putting in the presentation that we used for the training or etc., I've also looked at other things like documents that I think might be valuable for your work. And like if you see, and there's little videos, so it depends on who you're training to. You could be training frontline workers and you just want to run through a quick video that shows the difference of why we use drops and when do we use injections, and I put them in there. And then there's also FAQs on questions that might come up that you have, and you just want something quick that you can look at. Aaron, if you click on the Word document that says Polio Basics, if it will allow you to, yeah, that one. And it's just set up in a very interactive way. It's quick, what is polio, etc., etc., etc. Thank you, Aaron. If we can go back, please. And back into one of the other folders. I appreciate you doing this. There we go. Yes. If you look at the next folder, it says country data, and then it says Sierra Leone, SL, and then it has Uganda. You can click on either, it doesn't matter. What I have done is when we are preparing for your trainings, all information that is shared with us that we help to customize and make these trainings will be in there. So if you need a quick document that you want to use and to show data, etc., look at different social data, you can go in there and they're all in there. Your Harvard polling results, everything are in there. So we just kind of group them again together that you can use them. So if we go back to another folder, I've also set up a folder for you in here that will have NOPV2, but you will see training manual, okay? That is a manual I'm going to speak to you about. When we start the training next week, you will get another folder like this that will have our modules, what we talk about, any documents that we think are useful. And the SOPs, of course, is quite straightforward. It's just the standard operating procedures. So when we did that presentation right in the beginning that I was doing, when we were breaking it down by 72 hours to 14 days, etc., etc., that's where your SOPs are that you can go and look at. And then if you look at, if you can click on resources to share, voila. So here are some of the documents. I only see, I will look at this again because I see I didn't put some of the training materials in here, but the documents that I speak to you about, that we talk about, that we think are relevant, that will help you, that will save you time, will all be in these folders too. Now, besides these tools, of course, thank you, Aaron, I'm done with that. Besides these tools, of course, they are the platforms that I spoke about that you can go to and you can get all of the documents that you need. Even if you were doing some work in the field and you really needed some support, go to Rhizome or go to the GPEI website. But with regards to the training, we've made your folders and everything will be in there. And then hopefully by the end of the day today, I will go through the agenda and see what other documents were missing that we thought were relevant, and we'll add them in there. And then if there's anything else you need, you can always reach out to us personally. Okay, Thank you. So while I'm pulling this up, Aaron, if you want to see what were some of the questions in chat, and I'll pull up the next presentation.
Yes, so the chat comments are asking about this link to the materials we were just looking for. So you have that link in the chat box, and I will send the link out via email so that you have it permanently in your email and can easily reference it at any time that you need that. So following the training, I will send that out to all participants whose emails that I have.
Yes. And just a reminder, it is to do with the documents that we reviewed during anything that we were talking about in this training that we thought were relevant and need to be shared. That's what's in there. Okay, and now I'm going to, when I try and share my screen, Aaron, did you disconnect?
It should be now, yes, you should have the ability.
Okay, because my stuff's not showing up. My apologies, people. Let me just try and jump out of here for a second.
I can also pull up the supportive supervision PowerPoint if needed.
I'll try once more, and if it doesn't work, I will have you do it. Yeah, for some reason it's not. Oh, sorry, I must be not completely awake. It asked to share screen. Can you see my screen?
Yes, I can see your screen. We just need exactly the presentation mode.
All right.
That looks great. Thank you.
Thank you. So what I'd like to take is a few minutes just to talk about supportive supervision, facilitation, and training, because this is something that we all do. I mean, we have our professional backgrounds that we come in. Something that I think is important and it's critical, we usually do this at the beginning of trainings, just to remind all of us and to remind our colleagues that when we go out there and all these different layers, that we have thought about this, and they are also in your file folders. You will find tools that can help you to do your work. It also came up, I mean, even just in the last conversation we were having, where I think it was Douglas or it might have been Emmanuel, where we were talking about this, or someone wrote a text about talking about IPC, and when you look at microplanning, the importance of having supervision present. Okay. All right, so our roles, as I always remember, is to be a facilitator. We have to remember that we are there to also help teach people who are a little less experienced in what we do. Yeah. I always say that just because we have the technical knowledge, it doesn't necessarily mean that we are good instructors. And so we have to take the time sometimes to just sit and reflect and to think about how we can actually help to improve the skills of the people we're working with. How do we create environments that are positive? Have them participate, have them be part of the process. We are C4D officers. That's a big part of what we do, is this participatory exchange, its inclusion, et cetera, et cetera. And how do we act as coach and mentors for our colleagues that we work for? Something that I think is important for us to remember, I think when I looked at your names, I saw there were a few health specialists in the room. For those of you who remember when you were in medical school or public health courses, one of the things that we like to look at are PBLs, like how do we do these problem-based learning things? And I like to take that and then just look at it as how do we train people when we look at how adults learn, because they learn very differently than how children learn. And are we thinking about these principles of what we do and how do we include them into our trainings? And can we mix this methodology? Because they do already come from a lot of experience or technical knowledge, but how do we pull out what we want? So we look at like problem-based learning, which are PBLs, which we mix. Fortunately, we can't do that so much in Zoom, but we're on the ground. We need to remember that. Of bringing in scenarios and just a mixed process. Do we take into consideration our LLNs, which are low literacy numeracy populations? A kind reminder that a lot of these people, it doesn't mean that they're stupid. It just means that they might not be able to read. I think about my grandmother back in the village. She was a very intelligent woman and who taught me a lot. That did not mean that she lacked intelligence in what she was doing. And what are the tools that we are creating? And are we making sure they are available to people who come from these different LLN groups? Okay, I put in your learning folder, these are like posters that I made, and we blow them up and we like to put them in training rooms. I think they're very effective for colleagues as they are for the people that we are training. This is just to remind people that when we do our trainings and when we work as coaches and mentors, that people learn on differently. As I mentioned before, I'm a very visual learner. I like maps, I like color. I find it very effective. It keeps me interested in what I'm doing. Some people prefer to just listen. They run, they walk, they use podcasts. Some people like to read things, and some people like to try things. They like to open up a box and just try and do it first. And if it doesn't work, then they go and read the instructions. So again, when we train, are we mixing these things in our training processes to make sure that we're being effective in what we do? And this is just a show, do, tell. We're all different. Again, some say show me, some say let me do it, and some say tell me how to do it. And these are in your learning folders. I have this over here to remind us that when we do our work, my training is going to be very different when I'm in Afghanistan versus when I'm in Uganda or in Sierra Leone or wherever I'm with my colleagues in New York. It's important to remember to go back, review the data, understand your audience, and then customize it. And customize it based on what you are training. Farhad usually speaks about this, and when we're closing out outbreaks, we're moving at a very quick pace. We have a lot of pressure from donors, from country teams, from headquarters. And so how do we do this work, and how can we customize it and narrow it down to understand what the issue is? When are we using our IEC? When are we using our IPC? Please go and review your data and do your customization of your training. As Aaron showed you from those folders that we put up, for us to do these trainings, that's what we had to review. We go into the country programs, we look at the data that's been given to us, we look at what the situation is, and then we come back and we see what can we customize to help make the training a better experience. As talked about before, we have created a facilitation manual. As much as we facilitate, checklists are great. I forget things sometimes. I need to go back to the drawing board. It's just a quick, easy read. It will just remind you of certain things that we need to think about when we go forward in our trainings. You know, we might think sometimes as C4D officers, and unless I have my BBM colleagues there or my health specialist, I might not even remember to, did I have my vaccine vial carriers? Do I have samples of the vials? Do I have the chalk to show how you do the door-to-door marking, right? I might just be thinking completely in the opposite direction of tally sheets, etc. So these are when these checklists are very helpful for us to be organized. Think beyond polio. Polio program has been doing this for a while, and we're actually trying to strengthen this a lot more. Try and integrate our services. We've talked about a lot of different things. You brought in examples of Ebola. When we look at cholera, think beyond this when you're doing your trainings. Routine immunization is going to come up. Water and sanitation is going to come up, especially in the context of COVID-19. So when we are training, yes, we have that IPC time, but are we doing this, and are we making sure we're prepared that these questions might come up? Okay. Think about our rollout plans. I use this as an example because a lot of times people think that when you're doing a training that you have to have these very elaborate rollout plans. And I say no. This is an example of a rollout plan that we literally do in a training on a wall with pieces of flip chart paper so that it can be very interactive and we can discuss about what's going on. And I believe I might have done this one when I was in Somalia. So it's just a reminder that we could just do it in any form that's present. It's after that that we can take it and then we can elaborate on what we want. And by doing this in this way, we can actually look at it at different levels and see whose responsibility falls in where. Okay, a reminder that we talked about this at the beginning. You are going to be doing house-to-house campaigns. You are doing it in the context of COVID-19. We did put the guidelines in your folder for you. Please review it. There's an example. We spoke about this before. Things that you will need to consider as teams of how this will change with the normal campaign that we used to have before versus what's happening in the context of COVID-19. Also, if you look at your IEPC activities, which will be very different, remember to always look at what the government also has in place as we follow lead with government. This is a feedback loop that I used for trainings and I continue to use with my colleagues to remind me and keep me focused in my work, and it might be helpful for you. It just reminds us that when we train, we look at the training of what we're conducting, we look at our audiences, we like to figure out what knowledge they have when they're coming in. We do this through daily evaluations just to help us, and little sessions where we get feedback information. We look and see what we do when we operationalize it and we're in the field, what is working, what isn't, where support comes back, and we take all this information. And after campaigns, we feed it back in. So we look at the data we're given that comes from the field, how it worked in the field, what our observations are, and we take all that, and then this is how we come back and we adjust our training. So it's this continuous work that never stops, that's always ongoing. And if you look at the outer circle, I put that there because it's a reminder that if we want to make impact, which is long-term, it doesn't happen overnight. The only way we can do this is to continuously look at this cycle and to make sure we're adjusting it based on the data that's coming in, what changes and gaps need to be addressed. And that's how we approach our the training process. I want to talk about soft skills really quickly for a second, and I will ask you a question. When I say to you soft skills, what comes to your mind? Why do you think it's important for us to talk about soft skills such as supportive supervision, coaching, and mentoring? Besides my little words that I have on that sheet over there. Anybody?
So feel free to find the chat box. I invite you to write your responses there or to simply unmute your microphone.
Hello, Lauren.
Yes.
This is Martin. I think you're right, and I think we need to talk about soft skills. I think in the perspective that we need to appreciate that we are dealing with the people. We are dealing with people of different categories, different social backgrounds. And it's very important that when we are dealing with them, sometimes what matters a lot to them is how are we valuing them? How do we look at people in that context? We may be specialists, we may be specialists in our various fields, and they may not even be educated, but do we value them as persons? How do we interact with them? And this all will actually give them a sense and acceptance, and also to participate in whatever messaging we are doing, programming we are doing, and actually at the end of it all, we'll be able to achieve our intended goals and objectives, because they will be very supportive and participatory in all the process. Thank you.
Absolutely, Martin. Thank you for that. Yes, very critical. Yeah, our emotional intelligence, everything when we look at motivation, how do we keep them going, etc. Anybody like to add anything to that?
Go ahead, Umhala or Metzger in the room.
Yeah, good afternoon again. I want to believe soft skills as supervisors. One thing we should know, we are not going there when we are doing our supervisory visits. We are not going there to do policing or fault finding mission. We're going to help them improve their knowledge, being supportive, and there are times You do mentoring and coaching, and the manner in which we do it, we should be respectful. We respect their views. Are not being, no, I am here. You do as you're being told. No, we have to be very polite, you know. I think being supportive, and we create a room for questions. Let us allow them express their own way of doing things, but in that kind of manner, being polite and being, at least make them feel comfortable when you are going there for supervision. And after which, let's give them feedback at the end of the day, our findings, what we gathered. We sit them together, give them feedback. Explain to them what and what they need to put in place, what needs some modifications. I think by doing that, these are some of the things I feel they are soft skills. We have to be accommodating.
Absolutely. Thank you. Yeah, and it's respect. And a lot of these people come from the communities that we are trying to gain entree into these communities, right? They're also our eyes and ears on the ground. There's a lot we can learn from them. And how do we keep them motivated? And the respect issue, right? I'm going to go on to my next slide. So just a reminder that soft skills are professional, they are transferable, and they are part of personality, right? This is critical. How we behave, how we communicate, how we talk to each other is so important. I mean, look, a lot of us work with UNICEF over here. Just look at the competency test we have to just go through to get a job with UNICEF, right? So it's always a good reminder that when we are doing this, what do we expect to take into the field when we're working with our colleagues too, and bring that respect with it. So let me ask you, why is supportive supervision so important when I say that? I'm sure a lot of us in this room have been or are supervisors, and what is one of the key critical things we want to see the role of supportive supervision in our programs? Besides the empathy part, besides the emotional intelligence, what is the other reason that supportive supervision is critical?
Supportive supervision. We're going to achieve results. Yeah.
Absolutely. Absolutely. We want to achieve results, right?
But we don't pick up.
So we have the whole emotional part that we have to do, the respect part, the emotional intelligence, the care, the concerns, the motivation, and then we have the part which our donors, which our programs say to us, and that is improve the quality of work, increase performance, and improve knowledge. Yeah. And the more you see that we start to do these trainings, we will start doing a lot of technical. Of course, we'll always be there, but we also have to focus quite a bit on the soft component of it. Okay. Just a reminder too that we do work as coaches, we do work as mentors, even for each other. And then when we do our work, let's make sure that we remember when you do go into the field, as Uma was saying, step down for a minute. Let's not be so authoritative, and let's think about these things. Explain the skill. Remember that show, do, and tell. Demonstrate when needed. Have the health worker practice. We know that we retain more information when we do that. Be constructive, not critical so much. And record the results so that you can feed it back into that feedback loop so that you know where we can adjust our trainings. Okay, so that was just a quick part from me on the supportive supervision part that we are trying to strengthen. Are there any questions or inputs or anything?
Thank you, Lorraine, for this presentation. If you have any questions, the chat box is open, or please unmute and make your comments or your questions. We'd love to hear from you. Anything to clarify or anything that you'd like to add about the topic?
All right, it's also getting late. I want to bring up, last but not least, a quick presentation. Please bear with me. I don't know what's going on over here, I think.
So as Lorraine's pulling up the next presentation,
which is very quick. It's just a couple of slides about what we're doing in the next training.
yeah, so please feel free to take a minute, stand up, take a quick stretch, get some movement, some fresh blood, just to keep us thinking through our last presentation of this afternoon. Be giving a quick introduction into the NOPV2 training.
Aaron, I might have you pull it up. I have
Sure.
that horrible blue wheel
Yes, no problem. Okay.
coming up. I have it, lady.
Okay, you beat me to it.
All right, let's see if it projects though. I might have spoken too soon. I'm having problems. I might have to have you do it. My apologies. Oh, I think it's working. Oops. Aaron, are you there?
Yes, I'm also just, I think our computers are also tired on a Friday afternoon. So let me just put this in presentation.
Oh, so you have it. I thought I dropped off. Okay.
Okay.
And you took that out of the Dropbox that I just shared, right?
Yes, this is right from the link that participants have.
Okay. Before we sign off for the day, I just wanted to talk briefly about the NOPV2 training. And Tommy's online with us, right? Yeah, great. Which we will be conducting. So what we did was we split the trainings as two. One of them was the outbreak preparedness and response, so that we could remind colleagues of what tools, et cetera, and the way we go down with that training. But then we have the NOPV2 training that we prefer to look at as just a module besides the outbreak training that you've just gone through. So what we would like to do in that training, of course, is to introduce participants to NOPV2, look at the key messages that will come out of it, look at the guidance notes, the positioning messages that you've heard being discussed. Tommy and Mariana have brought this up a few times. And then we will also be looking at, yes, this is session 12. It's just, you can open it, and but you, oh, that's from Aaron, never mind. And then look at IPC because it's critical. These are issues with the introduction of a new vaccine, so we would like to discuss that component of it. And that part of the session will just be done in breakout rooms. We'll spend a lot of time in the breakout rooms reviewing some of the questions, and that will have to do with like EUL, talking about NOPV, what comes up with these CVD-PVs, working in the context of COVID, etc. It'll just be breakout sessions and plenary after that. And then one of our colleagues will be online from the regional offices to provide support, whether it is with ASARO or CARO or Anglo, with the whole VBM component of it. Before I hand it over to Tommy to add to that, let me just see what else we have on these couple of slides. So next slide, please. Oh, yes. One of the things that we might discuss and bring up, time permitting, is that what do we do when we look at our training plans? A lot of times, as we spoke, you will be looking at your communication strategies and the advocacy, et cetera, but also because we are training on that, what will we look at to make sure that you've taken these things into consideration when you roll out the trainings for NOPV2? Next slide, please. And time permitting, if we do even have a couple of minutes, one of the things that we might touch on is some of the research that we conducted before we started developing the training curriculum, et cetera, and the strategies for NOPV2 that was done by FHI 360. Next slide, Aaron. And one of the reasons I think it's important that we just touch on that is also because, as we say, you know, we use a lot of evidence-based to do our work, and just to show you the results of how we looked at overall the polio vaccination, VDPVs, then NOPV, what would happen with the introduction of it, a one-drop strategy when we were not sure what the vials would look at like, and the trusted information. If we will not discuss that because we don't have time, just a reminder that those folders that we did show you, I have already put the research that came out of there in there. Aaron, is there any other slide, or that was it? That's just the methodology. So as I mentioned, we've set it up for 4 hours right now. They will be maybe a couple of presentations. They'll be very short. We will do a lot more work in the breakout rooms, and we'll have a question and answer sessions. And yeah, this one that's not really necessary. That's just to show, so that, you know, there's two parts, because they will be the messaging that we look at as TOTs, right, on this level when we discuss some of the issues. Umu, you also brought up earlier. I would like to know, how do you do the messaging for the CVDPV based on ABC? But then there's also the other part of the messaging. How do we take the messaging down to the frontline worker level? And that's why I have this slide up, because that's something else we would like to discuss in the training, because we do have different audiences. So thank you, Aaron. If you just go back to the second slide, and we'll leave it, I'll show you where, this one. And I'll just leave it here, and I would like to open it up to Tommy. Tommy, if there's anything you'd like to add to this. And I think it kind of also talks a little bit about what Douglas was talking about, having those different strategies in place when we look at NOPV2. Over to you.
I don't really have much to add. We also talk about the requirements of the country to prepare themselves for the NOP introduction. There's a long checklist of plans and documents that need to be collected, and I already said that in terms of communication, there are three items that have to be completed and then verified by a verification committee, and I sit in that committee. So basically, making sure you have captured all the key critical elements in those plans. The advocacy plan, the crisis communication plan, and the C40 plan. So before all the documents have been completed and approved by GPI, the sign off of the vaccine will not happen. So that's the process, and I'll talk about that more during the training. And I think Nasir is on the call too. So I don't know if you already talked about the date for this training. I think we had considered 19th of January for Sierra Leone and Uganda, if I remember correctly.
Nasir, I think he's on the call. Yeah, that's what we considered, but I think this would, I'm not sure if that was still tentative or it was 100% approved. And
well, we need to get the countries agree that that state is convenient for them.
Yes. So he is on the call, but he's on mute. And oh, I see Mariana's on the call too. She might be on mute too. Hi, Nasir. Salam.
Yeah, I just I muted. Do you want to say? I just missed. Were you making any point for me?
Yeah, we were just considering the NOPV introduction training. So at the headquarters level and with Geneva, we had considered 19th of January being the NOPV session for 4 hours for Uganda and Sierra Leone. So we would like to make sure maybe you can check with the countries that this is convenient for them.
19th.
19th, yes.
Okay, I'll just check it. It is what.
Yeah.
I'll get back to you. I'll check, and because Miriam, who is the contact person for us, she's on leave today and yesterday. So Monday I'll check with her and get back to you. Yeah?
Sure, Nasir. And I think we're doing it in collaboration with the Wakaro, so it will be also with the Sierra Leone team. So we'll have to check regionally with Mariana and all in Geneva to see how we're going to pull that together.
Absolutely. Yeah. And NOPV is important because for both Kenya and Uganda, they are added to the list, so it's very important for them. Yeah, I'll definitely make sure I discuss with them and get back to you.
Okay, and for my colleagues, like I said, we have that folder, and then as we know more at the beginning of next week, I will go ahead and open up the folder for the NOPV2 when we have the documents in there, because there might be a little bit of heavy reading. I think it would just be a little more helpful before we go into the training, as we only have 4 hours on the Zoom of training. So I will try and make sure that we're able to do that. So I'm going to hand it over to any other questions that we might have out there. Aaron, do we have anything in the chat?
We have a hand from Douglas. Douglas, go ahead.
Yeah, thank you very much. I might sound a little bit uninformed, but I think let me just push this forward. I just wondered, this is quite specific to polio, but when you look at the structure and everything, it cuts across and can be adapted. And I was thinking in terms of where we are going in terms of COVID-19 and promoting the vaccine. If we can adapt this, and or if New York can help us to develop something similar for COVID, specific to the COVAX, so that we kind of utilize the same structure and theory to orient our partners, because I know the demand on C4D is going to be tremendous once the vaccine is out. Thank you.
Okay. Douglas, this is Lorraine speaking, and happy to provide support where we can, just to bring this back in the context. Yes, you're absolutely right. This is very cross-cutting. I mean, I've only been in polio for the past 6 years, and before that it was bringing in the knowledge of other stuff and bringing it into polio, and vice versa. At the beginning of the year, we actually provided support to the immunization team, and what I was doing was helping to develop training sessions that were very similar, taking a lot of the experience and knowledge from the polio program, and how we could incorporate that in there, especially when we were looking at the community health worker level. Happy to discuss it further. I think you guys have my email address. Tommy's there, Mariana's there, but please, let's do bring this forward, because there's a lot that we could learn, and also that the knowledge that what we can pass on from the polio program, which you have seen has come up quite a bit in the COVID response, both globally and within the agency.
Okay, thank you.
Mariana, would you like to come in here?
Yes, please. Thank you, Douglas, for a good question. I just want to reconfirm that both vaccines are being introduced under the emergency use listing. And we will talk more about it next week or in 1 week. But the verification checklist that Tommy just mentioned is very similar for both vaccines. So basically, I'm currently supporting Liberia country office, and what they're doing, they're using at a country level, at a government level, they're using this process to also preparedness process for the NOPV to prepare themselves for COVID. The messages will be different, the target audiences will be different, but the capacity building part of it and the principles of it and the checklist and verification are very similar. So absolutely in line with your thinking. And as Lorraine said, please let us know, and we either will support from our side or we will connect you to relevant people who are dealing with COVAX at the global or regional level. Thank you.
Yeah, thank you. And Mariana, and Douglas, to add on that, Mariana's absolutely right as the EUL stuff. And just a reminder that one of the main differences is the NOPV2 is oral, right? And then when we're looking at the COVAX, we're looking at syringe, which might be similar. I don't know if you were working with the programs when we were looking at the IPV, right? So I think that might be where they'll only be, when we look at the audiences, as the health worker might slightly shift, of course, because it's intramuscular versus the drops, but otherwise a lot of the context is the same. And that might look more in the direction of the IPV that came in a few years ago. Yeah.
But also there's a critical difference, which is that COVAX will be facility-based campaigns, or not campaigns, but so you need to pull people to come to the facilities, and there's always more challenging than when you show up on their door. Anyways, but I think I agree with everything that's been said. But I mean, there's that big shift in the communication strategy has to be there when you try to attract people to come to the facilities. So
absolutely. So you're completely right, Tommy, which is what we're talking. The audience might be a little different as far as like the health worker who we're training, and facility-based versus door-to-door. Demand that whole diagram thing of working on this side versus this side where we just come and we give it to you. Yeah. But
yeah,
very
already it is sounding very interesting here. Thanks.
Actually, I was going to say this was very, very interesting discussion, you know, and Douglas, if you want to even take it one step further, just call for a brown bag coffee session, you know, and pull out some of the people who have been sitting on this call and just say, let's just there's no reason we can't do this as colleagues, right? And then let's pull in a couple of those immunization people like Dr. Godwin Mindra and all, who work very closely on the ground, and just really start to initiate discussion. And like Kashan, you know, who's looking at the whole other side that comes in, and how does this all fit together? I mean, there's no reason why we couldn't even start that in like 2 weeks or something, and just do it over lunch or something, just to start the conversation. Yeah.
Yeah, noted. I'll follow up with our team and see how we go about this. Let's see what the demand and the implications are to us. Thank you very much.
Thank you. Anyone else? Any other inputs? Farhad, Kashan?
I just want to leave a little note for all the participants that, guys, everything that you've seen today, it's a lot of information. And with all the team over here, please feel free to reach out to any of us whenever you have any relevant queries or support requests, and we'd be happy to create individual sessions on specific things that you need support with, especially around misinformation. I look forward to connecting with you guys over the next couple of days to discuss the dashboard that we have for both Uganda and Sierra Leone.
Yeah, thank you. Anyone else? Sorry.
Right.
Yes, Farhad. Thank you.
I just want to echo Kashan, saying that yes, we extend our support to country offices and in preparation for the NLPV introduction. But I'm very confident that there's a lot of knowledge and skills within the countries, and I trust and rely on this a lot. You have the knowledge, you have the knowledge of the country, of your people. So we basically can help and facilitate your own planning and implementation. And of course, we can come up with resources. Thank you. Thank you for your participation today and previously.
Yeah. Thank you, Farhad. I'm going to hand it over to my colleague, Tommy, if you have anything last minute, or Mariana, before we close out.
No big final words. I think it's been interesting, and it's definitely comparing to how we did it with Liberia. It's a sort of a different type of discussion and engagement. So it's good. So, but that just tells us that these trainings need to be tailored to the audiences. As communicators, we know that we have to know our audience so we can have a more effective messaging and communication with them. So it's been a very interesting session, and I hope that we can set up the NOPV introduction soon. So Monday, Nasir will look into that so we can prepare for that also and have the right people lined up for the facilitation. So thank you very much for everyone for your participation.
Okay, thank you, Tommy. Mariana,
Yeah, just a couple of words. Thank you, first of all, Lorraine, Tommy, and the team, and Aaron Farhad for Kashan, of course, for conducting the training. I just wanted to also mention that I know that Sierra Leone is an active phase of preparation for NOPV package. If you have any questions in between on the documents, on the checklist, etc., please reach out to myself, Claude, and Farhad, and we'll give clarifications. It is a cumbersome process, and there are a lot of demands on the team, we understand. So we've been involved in this for the past 10 months. So we'll be happy to support, and there are RTs there to support as well. And I'm looking forward for the NOPV training. Thank you all very much for time and effort and all the great information. Thank you.
Thank you. Okay. All right, colleagues.
We have just one hand with, excuse me, Nasir. Did you?
Sorry. I just also want to echo my colleagues to really express, gratitude to the HQ colleagues, and also Uganda, and till yesterday Sierra Leone were also participating. Really it has been very good participation from the country colleagues, and very, very superlative facilitation by all the colleagues here. So as we just mentioned, that next week, or maybe 19th, we are planning to do this NOPV. This is extremely important, and as colleagues from Uganda know that they are going to be involved in the introduction of NOPV, and it's going to be very helpful. So from the regional office, I would really be very happy to facilitate and coordinate the planning of the support which will come to you at the country level. So Mariana was a very helpful and involved in the planning, but she had to attend certain things. She's not here. So thanks again to the whole Uganda team, and also Mandy and Miriam to really make it happen.